visible.
Okay. Thank you for inviting me in the Bangladesh, but only thing is that I'll not be able to present physically to get your warm reception. So anyway, this is a story of a 58-year-old lady presented with the dysphagia and the solids only. Non-diabetic, hypertensive, controlled, fairly controlled, past history of pericardial effusion, which was treated conservatively. But there is no other significant history and the unremarkable clinical examination. This is the first clip. When you saw the parasternal long axis view, you can see a mass within the left atrium. It's a variegated appearance, and it is spilling from the almost whole of the left atrium, keeping a small area aside. In the short axis view, you can see LV is fairly contracting well, and that too in the RV. And in the short axis level, in the aortic level, you can find the same mass in the left atrium. And as if it is arising from there is a clear gap in around the LA, but it's almost variegated in appearance. And some areas are something like cystic degeneration. RV eye product and the pulmonary arteries are all normal. Flow is absolutely normal. In the four-chamber view, you can see the mass is almost in the center of the left atrium, and not hinging into the mitral inflow tract. And there is a huge mass. This is the solid part, and this is the cystic part, and there is some equiescent area within the mass. And another view, we can see the mitral mitral valve is moving freely. In fact, mitral inflow velocities and the LV outflow tract velocities flow is absolutely normal, leaving behind a little bit of aortic regurgitation. There is a grade 1 or 2 aortic regurgitation. And this is a zoomed view. You can see there's a huge mass. There is a huge mass covering the whole of the LA. In fact, we could not find any origin where it is arising from, whether it is from the septum or it is in the which particular valve. But this is a very large mass at a variegated appearance with some sort of cystic degeneration-like thing. Same thing in the subcostal view. You can see this mass around whole of this area with the cystic degeneration around. You can see the superior vena cava flow is okay, and you can see even the pulmonary venous flow inside. So before going into the CT scan, we thought what is the possibilities from the echocardiography, from the point of view. We thought there must be some mass, could be it is a myxoma with the cystic degeneration or any other LA mass. We could not exactly do the diagnosis, but this is the working possibility. Keeping in this mind, we did not do the transesophageal echocardiography. We gone into the good CT. When we did the CT, what we will find surprisingly that this mass is actually sitting around the LA, not in the LA. Is over the LA, and in fact this is the mass probably is close to the ascending aorta, and you will be very clear in this picture. This is the mass and this is the ascending aorta, and there is some communication is coming from the ascending aorta. Go to the another picture. Same thing is a mass, something arising from the ascending aorta and all of the aorta. When is the tomography, now in the tomography view, you can feel this mass is huge mass with this area is where what we see in the echocardiography, some cystic degeneration like thing, and it is arising from the aorta. And from the CT scan, they are telling, reported as that is a case of mass arising from the ascending aorta, probably the aneurysm from the ascending aorta. Then we did the CT angio. And here it is absolutely clear. You can see this is the mass which is arising from the ascending aorta, and this mass is we are able to see. And this is the mass in the CT angio. So basically this is not a mass within the LA, and this is the mass arising from the aortic aneurysm and arising from the ascending aorta. But why did he miss it? Then this patient was put on the OT. And when during the OT, what happens? We did the intraoperative transesophageal echocardiography, where you can definitely demonstrate this is the mass and this is the ascending aorta with the aortic valve, and you can see clearly the aneurysm with the flow from the aorta into the mass of the aneurysm. And this is the operative patient. But very important thing, why did you miss this in the echocardiography? Why did you miss it? So looking at this, we reviewed the picture again. Then when you go to the subcostal view, we find there is some abnormal flow is coming in the subcostal area. Now, if you zoom this area, what you will find, this is the flow, you can feel this is the aortic regurgitation, and some flow probably from the aortic region is going into this mass. You can see the flow inside. So if you review these slides very carefully, then retrospectively thought we have missed it. So what has been done in this patient? There is a unique treatment has been done that is called frozen elephant trunk procedure by Dr. Atanusa in RNTCs. I'll give a schematic video how this procedure has been done, because this is a unique procedure, and this procedure was done in this patient, where a wire is put into the femoral artery by a device, and it's called rinsing of the delivery system. First, you rinse the delivery system in this area with preparing the device, and then you mounting the position of the delivery system. This is the area you mounted it, and then inflation of the balloon tip for smooth transition from two tips, whether you can enter into it. And as you go, when you cut it from the ascending aorta and the descending aorta, you put the device into the descending aorta, and then by the device from the outside, you position and guarantee the optimal stent graft placement during the deployment. And you can gradually deploy first the distal part, and then the middle part, and then in the proximal part. Then delivery of the balloon tip for the safe removal of the delivery system. What happens after that? We take out the delivery system, and then suture this or collar facilitates the anastomosis with the vessel and they compensate for the diametric mismatch, so that the diameter become matched, and then take out everting the vascular graft into the ascending aorta, and then reimplantation of the head vessels by using this island technique. And ultimately, the whole reconstruction has been done in the OT itself and by the device. And in this patient, it was done by the same way. And you can see this is the open, where first the ascending aorta was cut open, and then the some sucker was given into the DTA, and then preparation of the evita stent graft, and then you can see the entire process of catheter guided delivery. You can see the catheter guided delivery within this catheter guided delivery, and you'll be able to into the deliveries into the descending aorta, And then the device was inflated by gradual way. Gradually, the impression was divided the same way by the schematic diagram. Then everting the procedure. Then the distal responses of the cup of the trunk with the DTA. And then pulling up the graft from the ascending aorta. And then suturing this, the graft. After the next the arch island was sutured, and this is the final result. And after putting this final result, you can see that everything, the post-operative CT angiogram is showing is like that. This is the post-operative CT angiogram of this patient. The patient had a smooth post-operative release and a drop on the day 3, and this patient was discharged. Thank you.
Thank you, sir, for your excellent